Hey everyone, welcome to a deep dive all about infection and antibiotics. We're focusing on stuff that's going to be super useful for orthopedic residents, especially those of you getting ready for those big postgraduate exit exams like the FRCS or equivalent. We'll be going deep using the Ortho-Made Simple notes from mokyingren.sg. Those were put together by Dr. Mokyingren. He's a sports surgeon at National University Hospital in Singapore, and he absolutely smashed his FRCS exams back in 2022. All right, let's jump right in. We order lab tests all the time, right? CRP, ESR. But those aren't just numbers on a page. They can actually tell us a lot about what's going on with an infection, especially in orthopedics, though sometimes they can be a bit tricky to interpret. For example, did you know that ESR can actually stay elevated for like a whole year after a total hip replacement, even if there's no infection? So to kick things off, maybe you can help us understand this a bit better. What's the deal with CRP and ESR? And why does ESR stay elevated for so long after a hip replacement?
Well, you can think of CRP and ESR as two sides of the same coin. They both indicate inflammation, but they do it on different timelines. CRP is like your rapid response team. It shoots up really quickly when there's inflammation or infection, peaks fast, and then starts going down pretty rapidly as soon as the problem's addressed. ESR, on the other hand, it's more like a slow and steady investigator. Takes its time to rise and then can remain elevated for weeks, even after the infection's gone. The reason ESR stays elevated after a total hip replacement, even when there's no infection, it's because of all that tissue healing and remodeling going on, like a construction site after you've finished a major renovation. There's just a lot of debris to clear up, and that takes time.
So it's not always like a big red flashing warning sign. We need to consider the context, right?
Absolutely. You have to look at the whole picture, the patient's history, what they're presenting with, and how both the CRP and ESR are trending over time. One value in isolation doesn't tell you the whole story.
Okay, lab tests checked off the list. But before we get to the really fun stuff with antibiotics, let's do a quick recap on how we classify bacteria. I know it might seem a bit basic, but trust me, it'll come in handy for those exams.
It's all about knowing your enemy, right? Being able to classify bacteria, like whether they need oxygen or not, what shape they are, how they stain, all that helps us figure out what bug is causing the infection, and that tells us which antibiotic we need to use. Plus, examiners love to ask about this stuff.
Okay, let's talk about gram staining for a second. All
Sure.
about purple and pink, but why is that? What's the science behind that whole microscopic tie-dye party?
So imagine this. Gram-positive bacteria are like tough guys. Thick leather jackets, you know what I mean? Their cell walls are super thick and mesh-like, so they hold on to that crystal violet stain really tightly, gives them that bright purple color. Gram-negative bacteria, though, they're a bit more delicate, thinner cell walls, so they don't hold on to the purple so well. They end up picking up that pink counterstain instead.
So it's basically about how their defenses are structured. And that helps us figure out which antibiotic will actually work, right?
Exactly. Knowing the structure of the bacteria is like having a blueprint of the enemy's fortress. Different antibiotics target different parts of the bacteria. Some go for the cell wall, others go for the internal machinery. And by knowing that structure, we can choose the right weapon for the job.
All right, speaking of weapons, let's get into antibiotics. How do these wonder drugs actually work against bacteria?
It's kind of like this. Imagine a bacteria as a busy, bustling city. And antibiotics are like specialized forces, each with a specific mission to disrupt the city's vital functions. So you've got some antibiotics that act like demolition crews, targeting those city walls, or in this case, the bacterial cell wall, stopping them from building their protective barrier. Others go after the power plant, disrupting the bacteria's energy production. And some even go straight for the control center, interfering with the bacteria's DNA and RNA, basically the blueprints of life itself.
Wow, so it's like a multi-pronged attack, disabling the enemy from within. That's amazing. But we know bacteria aren't stupid. They can develop resistance and become these supervillains, like MRSA. How do they do that? How do they become resistant?
Think of it as an arms race. MRSA, or methicillin-resistant Staphylococcus aureus, has learned a new trick. It's got this gene called MECA that lets it build a modified protein. This protein basically acts as a shield, protecting it from methicillin and other beta-lactam antibiotics.
So it's like they've upgraded their armor, and our usual weapons don't work anymore. And how do bacteria get these new defenses? Do they just suddenly mutate into these superbugs?
Well, there are two main ways they can level up. One way is through random mutations. kind of like a typo in their genetic code. Sometimes these typos actually give them an advantage, like resistance to an antibiotic. The other way is through something called horizontal gene transfer. That's where bacteria actually swap genetic material with each other, like sharing sheet codes for a video game, you know? This lets resistance spread really quickly through the whole bacterial population.
So it's a combination of chance mutations and sharing information. It's pretty incredible how adaptable these tiny organisms are. All right, let's switch gears a bit. Imagine you're about to operate, and you find out your patient is MRSA positive. What happens next? What are the steps you take right away?
We go into pre-op decolonization mode. The main goal here is to reduce the amount of bacteria before surgery. That way we can minimize the risk of infection. We'll usually use a combination of things: intranasal mupirocin, which is an antibacterial ointment, and daily antimicrobial washes. We'll do that for about 5 days.
So we're trying to evict those unwanted guests before we start any construction. How do you know when the decolonization has actually worked?
We need to get 3 negative swabs in a row, each taken a week apart. That tells us the patient is decolonized. It's all about minimizing that risk, especially in orthopedics where those infections can have some serious consequences.
Okay, that makes sense. Now, let's say there's a sudden increase in MRSA cases in your hospital. What happens then? How do you deal with a potential outbreak?
That's a full-blown clinical governance emergency. We would immediately tell the clinical director and activate the hospital's infection control protocol. We might even have to put elective surgeries on hold, isolate infected patients, and bring in a multidisciplinary team, including infectious disease specialists to manage the whole thing. It's all hands on deck to stop that outbreak and prevent it from spreading any further.
Wow, that sounds intense.
Yeah.
How about the investigation side of things? How do you track down the source of the outbreak and make sure it doesn't happen again?
Well, a special committee will basically investigate every single step of the patient's journey, from pre-op assessments to how things are managed on the ward. They check everything from staff for MRSA carriage to operating room protocols and how clean the ward is. It's like a detective story, putting all the clues together to figure out where the weak link in the chain is.
It's amazing how much goes into controlling an outbreak like that. But what if it's you, the surgeon, who tests positive for MRSA? What's the protocol then? What do you do?
Well, that's definitely not a situation any surgeon wants to find themselves in, but it's so important to act quickly and decisively. First things first, I would stop all clinical work immediately and start eradication therapy to decolonize myself. Then I would tell all my patients about the situation, cancel any surgeries, and make sure their care is transferred over to my colleagues.
So it's not just about protecting yourself, it's also about your patients and colleagues as well. That's a huge responsibility. What about those patients you've recently operated on? How do you know they're not at risk?
That's a really important point. I would need to audit all my recent cases, see if there are any potential infections, and make sure those patients are getting the right care and monitoring. Transparency and quick action are absolutely essential in that situation.
We've covered a lot of ground on MRSA, from decolonization protocols to dealing with outbreaks. But there's another tricky infection that can sometimes be triggered by antibiotic use: C. diff. What is it about C. diff, and why does it seem to pop up when patients are on antibiotics?
Okay, so C. diff, or Clostridium difficile, it's a bit of a paradox. It actually already lives in our gut quite peacefully alongside other bacteria. But when we take antibiotics, especially those broad-spectrum ones, it's like wiping the slate clean in the gut. That disruption can give C. diff a chance to take over, leading to things like diarrhea and colitis.
So it's like the antibiotics create this imbalance, giving C. diff an advantage. How do you manage a C. diff outbreak? Is it another all-hands-on-deck situation?
Absolutely. Managing a C. diff outbreak requires a whole team. Infection control plays a really big part. Oral vancomycin is usually our first choice for an antibiotic, and strict isolation protocols are crucial to stop it from spreading.
So back to meticulous hand hygiene and isolation. Seems like those are key for infection control. But is there anything we can do to prevent C. diff outbreaks in the first place?
The key is something called responsible antibiotic stewardship. That basically means using antibiotics only when they're absolutely necessary, choosing the most specific antibiotic for the bacteria we're targeting, and using the shortest effective course at the right dose. It's about hitting those bacteria hard and fast, minimizing the impact on the gut's good bacteria.
So it's all about choosing the right weapons and avoiding unnecessary disruption. Let's switch gears to an infection that can be really scary: necrotizing fasciitis, also known as the flesh-eating bacteria. It's basically a surgical horror story.
It's definitely serious, and it can spread really quickly, so it needs immediate attention. It's basically when bacteria invade and spread along those fascial planes. destroying soft tissue and causing widespread necrosis, like a wildfire spreading through the body's soft tissues.
And there are different types, right? Different bacteria that can cause this scary scenario.
Yeah, we classify necrotizing fasciitis into 4 types, depending on the bacteria involved. Type 1 is polymicrobial. That means it's caused by a mix of different bacteria. Type 2 is usually caused by group A streptococcus, which is a particularly nasty bug. Type 3 is associated with marine Vibrio species, so we might see that in patients who have wounds that have been exposed to seawater. And finally, type 4 is caused by our old friend, MRSA.
Wow, so there's a whole gang of bacteria that can cause this.
Yeah.
What about gas gangrene? Is that a type of necrotizing fasciitis, or is it something completely different?
Gas gangrene is often linked to a specific type of necrotizing fasciitis, the one caused by Clostridium perfringens. This bug produces gas as it grows, and you can actually see that gas on x-rays. It's a telltale sign of this particularly aggressive infection.
Okay, so we've got this terrifying infection that can be caused by a whole bunch of different bacteria. But how do we know if we're actually dealing with it? Early diagnoses must be critical, given how quickly it can spread, right?
You're absolutely right. Early recognition is key if we want to save lives. That's where the LRNX score comes in. It stands for Laboratory Risk Indicator for Necrotizing Fasciitis. It's a brilliant tool developed by a Singaporean plastic surgeon, Dr. Wong Chin Ho.
LRNEC. That does sound familiar. Can you remind me what it is exactly?
Basically, it's a scoring system that uses 6 blood test results: total white blood cell count, hemoglobin, glucose, creatinine, sodium, and CRP. And it uses those to predict how likely someone is to have necrotizing fasciitis. It's like a quick checklist. A score of 6 or more means there's a very high chance of necrotizing fasciitis.
So it's really important for catching it early. But let's say our suspicions are confirmed. We have a patient we think has necrotizing fasciitis based on what we're seeing and a high LRNX score. What happens next? What do you do right away?
It's a surgical emergency. We need to act fast and hit it hard with triple antibiotic therapy. That's a combination of penicillin, ceftazidime, and clindamycin. If we think it might be related to seawater exposure, we add doxycycline to be safe. But antibiotics alone aren't enough. Surgery is essential to remove the infected tissue.
So it's a two-pronged approach. Antibiotics to fight the bacteria and surgery to get rid of that infected tissue. But surgery in this situation must be incredibly challenging. How do you know how much tissue to remove? And how do you make sure you're getting all the infected tissue while still saving the healthy tissue?
That's where surgical judgment and experience come in. We use something called the 3-zone concept to guide us. Zone 1 is the necrotic zone. That's the dead tissue that needs to be completely removed. Zone 2 is the infected tissue that might still be salvageable. We have to assess that carefully and debride it selectively. And Zone 3 is the healthy tissue that we want to preserve as much as possible. It's like a strategic battle plan, carefully removing the enemy while protecting the innocent bystanders.
I like that. Really helpful way to think about it. But what if the patient is allergic to penicillin? That's one of the main antibiotics you mentioned. What do you do then?
Good question. We do have a backup plan. If we can't use penicillin, we can swap it for linezolid. It's another powerful antibiotic that can target those aggressive bacteria. It's all about being ready for different scenarios and tailoring our approach for each individual patient.
All right, so we've covered a lot so far. Lab tests, antibiotic mechanisms, and we've even delved into some pretty serious infections like MRSA, C. diff, and necrotizing fasciitis. But we're just getting started. Welcome back to our deep dive, everyone. We're tackling infection and antibiotics, really focusing on stuff that's going to be useful for you orthopedic residents out there getting ready for your big exams. Don't forget, this is all based on the Ortho Made Simple notes over at mokyingren.sg.
Absolutely. It's a treasure trove of high-yield information, especially if you're aiming for the FRCS or something similar.
All right, let's pick up where we left off. We've talked about some pretty scary infections so far, but now let's focus on a challenge that goes right to the bone, literally. Osteomyelitis. We've diagnosed it. Now, how do we actually treat it? How do we tackle this foe that's invaded the bone?
Okay, well, imagine it like a surgical renovation project. First things first, you need to get in there and do a really thorough debridement. That means removing all the dead and infected tissue. I mean, every little bit of it. It's like excavating an archaeological site. You have to be super meticulous to make sure you've got a clean slate to rebuild on.
So it's about getting down to that foundation, making sure there's no hidden enemy lurking in the debris.
Exactly. We want to see healthy bleeding bone, what we call the paprika sign. That tells us we've reached the bedrock.
Okay, so we've cleared out the infection, but now we've got this empty space. What do we do with that?
Dead space management is crucial. We need to fill that void to stop fluid from building up, because that can become a breeding ground for bacteria. There are a few different techniques we can use, like bone grafts or packing the space with antibiotic beads.
So it's like rebuilding after that demolition. We need to provide structural support and fill those gaps. What about soft tissue coverage?
That's another key part of the process. Soft tissue coverage is essential for good wound healing and to prevent reinfection. So we might use local flaps, skin grafts, or even some specialized wound care products to protect the area.
Kind of like dressing the wound after surgery, right?
Mhm.
Providing that protective barrier.
Yeah.
And of course, we can't forget about antibiotics. But there's always that debate, oral versus IV. Which one is better for fighting osteomyelitis?
Yeah, that's a debate that's been going on in orthopedics forever. Traditionally, IV antibiotics were seen as the gold standard for osteomyelitis, especially for the really bad cases. But there's been some recent evidence suggesting that oral antibiotics can actually be just as effective, at least for certain types of bone and joint infections.
So it's not a one-size-fits-all situation.
No, not at all. The decision really depends on a few things. How bad the infection is, what specific bacteria is involved, the overall health of the patient, and whether they can even handle IV therapy. It's a team effort working closely with infectious disease specialists to figure out what's best for each patient.
Sounds like collaboration is key here. Are there any guidelines or studies that can help us make these decisions?
There is. There was a really important study published in the New England Journal of Medicine. They found that 6 weeks of oral antibiotics were just as good as IV antibiotics. For certain bone and joint infections, including osteomyelitis, that's really changed things up. And now a lot of centers are moving towards oral antibiotics for certain
So it's
cases.
a more tailored approach now rather than just sticking to the old protocols. Makes sense. Now, we've talked about bacterial infections a lot, but there's another type of osteomyelitis that can be a bit of a mystery. Chronic non-bacterial osteomyelitis, or CNO. What's the deal with this one?
CNO, sometimes called CRMO, is a fascinating and often very confusing condition. Unlike those bacterial infections we've been talking about, CNO is an autoimmune disorder, so it's not about some external invader. It's actually the body's own immune system attacking its own bones.
So it's like a case of mistaken identity. The immune system is misfiring and attacking its own tissues. That must make it really difficult to diagnose.
You're right, it is. One of the biggest challenges is that cultures come back negative. We don't find any bacteria because there simply aren't any. It's all about inflammation driven by the immune system. Plus, the symptoms can look like other conditions, like bacterial osteomyelitis or even bone tumors.
Sounds like a real diagnostic puzzle. Are there any clues that might point towards CNO? Any patterns we should be looking for?
There are a few characteristic things that can raise a red flag. It tends to affect young females more often, and they often have periods of flare-ups and remissions. It also seems to prefer certain bones, like the clavicle, sternum, tarsals, ribs, and spine.
So it's about connecting the dots, looking for those subtle hints that might suggest CNO. What about systemic symptoms? Do patients with CNO generally feel unwell?
Yeah, absolutely. They often have pain, swelling, and tenderness over the affected bones. They might also have a fever, feel tired all the time, and even lose weight. And here's another interesting thing. CNO can sometimes be associated with other autoimmune conditions, like psoriasis or inflammatory bowel disease, which makes things even more complicated.
Wow, it really is a chameleon, mimicking other conditions and potentially affecting multiple systems. So how do we even begin to solve this diagnostic mystery?
Well, understanding the different phases of CNO can help. It usually starts with an acute inflammatory phase, where the immune system goes into overdrive and attacks the bone. Then you get lymphocytic infiltration, where these specialized immune cells called lymphocytes invade the area. And finally, you see reactive new bone formation as the body tries to repair the damage.
So it's a dynamic process with different things happening at different times. But before we jump to any conclusions, we need to make sure we're not barking up the wrong tree. What other conditions could look like CNO?
Differential diagnoses are so important, especially with a tricky condition like CNO. We need to rule out other possibilities, like Ewing sarcoma, which is a type of bone cancer, osteoid osteoma, which is a benign bone tumor, and even subacute osteomyelitis, which can have more subtle symptoms than the acute kind.
So it's like a process of elimination, carefully considering all the suspects before we can confidently say it's CNO. Are there any specific criteria we can use to help us make that diagnosis?
Actually, yes, there are. Back in 2007, Janssen and a few others published a paper in the Rheumatology Journal. They established major and minor criteria for diagnosing CNO-CRMO. These criteria include things like X-ray findings, whether there are bone lesions in multiple places, if the patient has psoriasis, the results of a bone biopsy, blood work results, how long they've had symptoms, whether they have other autoimmune conditions, and even family history.
So it's kind of like a scoring system, weighing different factors to reach a diagnosis. But let's say we've finally cracked the code and we're sure it's CNO. What happens then? How do we manage this immune system that's gone a bit rogue?
The good news is that CNO, while tough to diagnose, is often very treatable. The main things we use are nonsteroidal anti-inflammatory drugs, and SAIDs for short. Those help to control the pain and inflammation. We might also use IV bisphosphonates like zoledronic acid, which can regulate bone turnover and reduce inflammation.
So we have a few different options, from simple painkillers to more targeted therapies. But what about the more severe cases where those don't seem to be enough? What are our next steps?
In those situations, we might think about using TNF-alpha blockers. Those are powerful medications that target specific inflammatory pathways that are involved in CNO. They can be really effective for controlling those severe, debilitating flare-ups.
So we have a stepwise approach, starting with the basics and escalating if we need to. But what about long-term management? Is this something patients have to deal with for their whole lives?
Well, the course of CNO can be really different from person to person. Some people only have one episode, while others have those recurrent flare-ups. It's important to remember that CNO is a chronic condition. That means there's no cure. But with the right management, patients can absolutely lead full and active lives.
That's good to hear. It's all about empowering patients to manage their condition and live their best lives.
Absolutely. And it's also really important to emphasize that managing CNO is a team effort. It's not just the orthopedic surgeon. It involves rheumatologists, immunologists, and even psychologists to address both the physical and emotional challenges of this complex condition.
Okay, so we've talked a lot about CNO, the challenges of diagnosing it, the different phases it goes through, the importance of considering other conditions, and all the different treatment options. It's definitely a complex condition, but hopefully you all feel a bit more prepared to tackle it on your exams. And don't forget, all this great information is from the OrthoMade Simple Notes from mokyingren.sg. It's an incredible resource for anyone preparing for their postgraduate exams. Okay, future orthopedic surgeons, time to wrap up our deep dive on infection and antibiotics. We've covered so much ground, from those all-important lab tests to that really complex CNO. And remember, this whole deep dive was inspired by the OrthoMade Simple Notes from mokyingren.sg.
Yeah, they're an amazing resource, especially if you're getting ready for those postgraduate exit exams like the FRCS. Dr. Marker really boiled things down to the essentials, making all these complicated topics much easier to understand.
We've battled those bacterial bad guys like MRSA and C. diff, dealt with that surgical nightmare, necrotizing fasciitis, and even tackled that sneaky internal foe, CNO. We've gone through the ins and outs of managing osteomyelitis and highlighted just how important it is to have a multidisciplinary approach to infection.
And don't forget those lab tests, CRP and ESR, they're not just random numbers, they're vital clues when you're trying to solve that diagnostic puzzle, especially with orthopedic infections.
Absolutely. We also saw how something as simple as gram staining can really guide our antibiotic choices, and how scoring systems like the LR-NEX score can help us make those life-saving decisions in critical situations.
It's all about connecting the dots, understanding how things work at their core, and then using that knowledge in real-life scenarios. That's what makes this field so challenging, but also so rewarding.
Exactly. But here's a final thought to chew on as you continue getting ready for your exams. We spent a lot of time talking about bacterial infections, but what about those other troublemakers, fungi and viruses? How do they compare when it comes to orthopedic infections, and what unique hurdles do they present?
That's a fantastic point. They might not be as common as bacterial infections, but fungal and viral infections can be really tricky, especially if the patient's immune system isn't in top shape. They often need a different approach for diagnosis and treatment.
So it's a whole other world to think about. Keep that curiosity alive. Future orthopedic surgeons, the world of microbes is huge and always changing. But for now, you're well prepared to take on those postgraduate exit exams.
Best of luck with those exams, and don't forget about those OrthoMade Simple Notes from mokyingren.sg. They're a great companion on your journey.
And that's a wrap for our deep dive into infection and antibiotics. Until next time, keep exploring the exciting world of orthopedics.